Hello, everyone, and welcome to today's virtual panel discussion brought to you by the GAHE. My name is Guy Morris, and I am your session host representing the National Office for the American College of Healthcare Executives. We're glad you're here today. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session unless there is active discussion, at which point you may unmute yourself to talk, or the chat function will be available to you throughout the event. This event is being recorded and will be available in viewing in ACHE's learning management system in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 face-to-face credits applied within 2 weeks from today's event. We do encourage you to complete the evaluation for this event. The evaluation link will be in the chat box soon, so please visit before we close out today's session. Now it's my pleasure to introduce GAHE President John Cuven, FACHE, Senior Vice President and Hospital President, Wellstar Cobb Hospital, and Interim President, Wellstar Paulding Hospital at Wellstar Health System. John, it's all yours.
Thank you, Guy, and excited to welcome everybody. So good afternoon. Thank you all for being here. It's my honor to welcome you to today's virtual meeting of the Georgia Association of Healthcare Executives. Thank you to ACHE. Guy, thank you for allowing us to do this, the access to learning management system, so we can provide this face-to-face credit. Always good topics, and today we have a really packed agenda, but going to take just a few minutes for some important chapter announcements, and then we'll move on to our program, which today you can see in front of you is improving the health status of your community. I want to start our meeting, as always, by recognizing our sponsors. We really are deeply appreciative to these corporate partners. Wellstar is our platinum sponsor. Our gold sponsors are Piedmont Healthcare, Metro Atlanta Ambulance, Vocera, and Sound Physicians. Sponsors DT Spade, SSR Inc., and Vizia Technologies. I want to welcome our newest sponsor, Vizia Technologies. Vizia is a leading provider of fully managed real-time location systems, helping hospitals reduce costs, streamline processes, and improve patient care. I encourage you to go check them out. Their web address is www.viziatech.com. And truly thank you, Vizia, for joining our sponsorship and supporting GAHE. We do have some monthly meetings coming up I want to highlight, so mark your calendars for the third Thursday of the month. Some of our upcoming events as well. We have some virtual events coming. So on Wednesday, February 2nd, we have a Clubhouse event that will feature Jay Dennard, who is a fellow. Also, ACHE's Congress on Healthcare Leadership is still planned to be in person in Chicago, March 28th through 31st. Hope to see some of you there. And then please, for any of this information, you can visit the events page at www.gahe.org for details and links to register for our upcoming events. I do want to also highlight our scholarship subcommittee. And we're excited to announce that GAHE is offering 2 scholarships of $1,500 each for graduate student members in Georgia to attend the ACHE Congress. So we're looking to help offset the expense of the Congress that is, again, March 28th through 31st in Chicago. The application deadline for this is coming up pretty quickly on February 1st. For details, you can email admin@gahe.org. And then want to give a big thank you. This is a new subcommittee for us. Chet Basson is leading that for us, and we're very appreciative of Chet taking this on, and look forward to awarding our first scholarships. GAHE offers several ways to stay connected through social media, and you can see those on the page here, our Facebook group, LinkedIn, and Twitter. Please join us, follow us, and you can stay up to date on all things GAHE. We'd also like to invite you to get involved by serving on one of our committees. Programs like today do not happen without our committees helping lead this. If you're interested in volunteering, please reach out to us. You can email Bruce at admin@gahe.org, but we'd love to have you as part of the GAHE team. Today's program offers 1.5 hours of face-to-face credit. And our topic today is improving the health status of your community. As you can see, we have a really outstanding panel today. It's my pleasure to introduce our moderator for today's panel, which is Marion Spears Carr. Marion is also a FACHE. He's Managing Director, Healthcare Life Sciences Partners for Kumhar Partners. Marion has over 31 years of highly successful executive recruiting and talent acquisition consulting experience in the healthcare industry, a deep interest in leadership, organizational behavior. Marion has become a national speaker and training on the topics of team engagement, career development, and the power of personal and professional accomplishment. In relation to today's topic, part of Marion's search practice work is centered on organizations addressing social determinants of health, at-risk populations, and health equity in both urban and rural settings. He's also, and we're very appreciative of this, co-chair of GAHE's webinar subcommittee and has helped lead a lot of our innovation around how we partner through our webinars. If you've been around Marion, you know he is engaging and really excited for him to be our panel host today. And with that, Marion, I'm going to turn it over to you.
Thank you so much, John. Absolute pleasure, and always pleasure to be on the same panel or same discussion with you. And as you mentioned, this is an area that's really of interest to me. So I was very honored to be asked to be the moderator. But the story really is about our panelists. Fantastic group, incredibly well distinguished in their own rights. And I love the fact, frankly, that they're representing different parts of our state of Georgia. Our first, and I'm going to go through the introduction, and we'll get started. And for those of you who have questions, please post them in the comments or in the chat. At the end of the session, we'll have an opportunity for you to ask questions. As John shared with you, we're talking about improving the health status of your community. And I can't think of any better people to be on this panel as the lady and the gentleman that we have. So let me introduce Kelly first. Kelly Meggs is the Vice President of Marketing Strategy and Planner for Tanner Health System, West Georgia. Meggs has over 25 years of experience in marketing strategy, advertising, public relations, and corporate communications. Meggs is a bachelor's in journalism with a specialization in advertising from the University of Georgia. Go Dogs.
Go Dogs.
Go Dogs, yeah. I've learned that saying. I'm from North Carolina, but it's starting to be natural for me. And a master's in business administration from the University of West Georgia. She has facilitated and implemented award-winning branding strategies for Tanner, has managed numerous award-winning advertising campaigns, has directed the copyright design and production of award-winning websites, and a whole lot more. And she also directs their HR, recruiting, marketing, print shop operation, and employee wellness programs. You got to understand. So she's got this great background from a variety of areas. She's also very engaging in her community, which is what we're talking about. She is a Carroll County Chamber board member, part of the Women's Business Alliance, and a Rotarian. So Kelly, welcome. Thanks for being a part of the panel. The next person I want to talk about is Chris Kanan. A lot of you may know him. Probably most of you know Chris because of his activity in GAHE, but Chris has got this amazing background, 30 years of experience in the healthcare industry as a health system executive and management consultant. He joined Phoebe Putney Health System as a chief strategy officer in April 2020. And talk about a time to join an organization, particularly one in the throes of the pandemic. And he shares that. He'll share some about that as well. Prior roles, including senior vice president responsible for strategic planning and business development at Wellstar, and he's a former partner with KPMG. Throughout Chris's career, he's focused on strategy, growth, physician hospital operations and partnerships, organizational design. He has merger and acquisition, affiliation, relationship experience. He's assisted hospitals, health systems, academic medical centers, physicians groups, managed care organizations across the continuum nationwide to improve their market and their financial and their performance. He has a master's degree in business administration from Kellogg, which is an amazing school. He received his bachelor's, that's his master's degree in business. He receives his bachelor's from Duke University in my home state of North Carolina. And he's a former president of our chapter. Chris, thanks for being part of today's discussion.
Thank you.
And last but not least, an amazing background is Kurt Stunkel. He's FACHE as well. He's president and CEO of Atrium Health Floyd and executive vice president for Atrium Health. He has served his community for a very long time. He's currently part of this enterprise that Atrium has joined here in Georgia now. He's a member of the executive leadership team for that group. He leads Floyd Medical in Rome, Floyd Cherokee Medical Center over in Alabama, Floyd Polk Medical Center in Cedartown, as well as the Behavioral Health Center in Floyd, a freestanding 53-bed behavioral health facility. 26 primary care practices and 8 urgent care locations across 6 counties. He serves an amazing footprint in the Northwest Georgia and Northeast Alabama market. He also serves as secretary for Floyd Healthcare Management, which is a management company over a lot of those entities. He has over 30 years of experience working for Floyd, and Stunkel has served as president and chief executive officer there since 1996. So he's seen a tremendous amount of change and a lot going on, and that community engagement is going to be really critical. He's been dedicating to serve that community of Rome. He's past chair of the local United Way, American Red Cross for the Northwest chapter, and so much more. He's a graduate of the Leadership Rome and Leadership Georgia programs. And he's also Rotarian. I get to speak at a lot of Rotary groups, and I admire those people a lot. And he was honored with the Grassroots Champions Award from the American Hospital Association and was named CEO of the Year for the Georgia Alliance of Community Hospitals in 2008. And he's a current fellow. Absolute on point. Glad to have you, Kurt. Thanks for being a part of the panel.
Thank you. Honored to be with everybody.
Absolutely. So let's get the conversation started. And Kelly, I'd like to start with you. So we're talking about this idea of how to really just improve the health status of the community. And one of the key pieces is really around the level of commitment. And I'd love for you to share a little bit about what you guys are doing. What is the level of commitment from your organization to community health? And how is that commitment carried out in the community you serve?
Well, back in 2011, we started our community health division. We had always done a lot of community outreach, the blood drives, the screening events, CPR, but this really put a department together whose sole purpose was to impact community health. And in 2012, we received a grant from our local community foundation that really set the ball rolling, because no matter how committed you are, if you don't have the funds to back it up, then you don't really have a way to make huge impacts and have somebody who's managing it. And so from there, we received a CDC grant for $1,200,000. And that really enabled us to grow the department, align our programs with things that we designated in our CHNA and CHIP. These are the priorities in our community. And so that community benefit department became what is now Get Healthy, Live Well. But I will say, from our board and from our leadership, they are completely and totally committed to improving the health of our community. And that enables us to move forward our goals and to really impact our CHNA and our CHIP every season. Having that board support is key, because this is not a department where you're going to raise a lot of money and you're not going to obviously impact the bottom line right out of the gate. So having board and leadership in your court is paramount to success, especially for us.
And we're going to talk about this with the other panelists, but Kelly, one of the things about that commitment carried out in what you just described, tell me a little bit about kind of what impact you've already seen from that. And I know we're going to get into that later, but I love that question. I would love to know a little bit more about where you're seeing some changes already.
We've developed 10 coalitions, and the coalitions their goals were solely based around our community health implementation plan. So there were substance abuse, chronic disease management, a whole variety of issues that came from our CHIP. And their work is centered around achieving goals that we outlined in that program. The key is, though, we can't impact every health disparity there is in our community without community partnership. So from the very beginning, it was reaching out to people outside of our four walls, schools, other educators in the colleges, African-American churches, other churches, the law enforcement and government, all the way to DFACs and health services in our community. So it enabled us to really grow our sphere of influence and the ability to impact people where they are. And I feel like we've also are the Tanner School of Nursing. So we're able to reach out beyond our walls in ways we were never able to before, because you needed to get in front of them to make health impacts. And that starts a long time before anybody ever comes into our walls. So working with schools for safe routes to schools, doing things with classes and events in the community at where people are rather than have people come here has been a big part of our strategy. So we've been really excited about the progress we've been able to make over, I guess, the last 10 years.
And that absolute outstanding answer, Kelly. Thank you for, and that leads me into my next question for Chris. Chris, and Kelly mentioned that understanding what are the challenges in the community and the health challenges is really critical. And so the question I have for you is in what ways is your organization addressing these behaviors that could be impacting the health of community members? There's social determinants of health, like smoking, obesity, et cetera. And I know you guys have been dealing with that down in South Georgia. Can you share with us a little bit about that, Chris?
Sure, Marion, thanks. And you and I had spoken about social determinants of health, and it certainly that encompasses behaviors, but it also encompasses what you might say are enablers, such as housing and food deserts, or a new term that I've learned recently of food swamps, where there's concentrated fast food and high caloric. Of course, some days I think you could say that's a break room in all of our administrative suites, but
Exactly.
we won't address that.
Exactly.
And so in our case, similar to what Kelly said, we have a school nurse program. We have a long-time program called Network of Trust, which focuses on teenage pregnancies and reproductive responsibility.
Mm-hmm.
And we've also, in the last couple of years, started 2 community gardens. So if you had told some of us in healthcare for a long time that health systems would sponsor a community garden, I think I would have said that's unlikely.
Mm-hmm.
And yet right now, our pillar strategic goals for our community pillar, one of the metrics is how many pounds of food are we distributing in our local communities? So this idea of behaviors is elusive, and the scale is different. There was an article back with United Healthcare in the last couple of years saying that they had committed up to $500 million in improving housing for their enrolled lives. My first cynical reaction is only United Healthcare could afford $500 million, but we have to do it on a smaller scale. But I think scale is important, because when we talk about changing behaviors, you have to link your China reports with your service lines, with your on-the-ground activities. And we as healthcare leaders sometimes immediately want to talk about scale and how to affect an aggregate population, when I think changing behaviors is interacting and engaging an individual that over the longer term creates the broader impact you aspire to.
And I think you're hitting on something that I want to ask Kurt. I want to come back to all these questions that we're talking about with the panel as we have time. But you mentioned that building that trust in the community and that's where it starts. And Kelly also talked about this community engagement. Kurt, and I'm really familiar, even though I'm not from your region originally, I've gotten to live in the the region of you where you serve, and you know, you and I talked about this when we had this discussion about this building the relationship. So my question for you in the community is for you and your communities is, how do you open that dialogue with those local leaders to discuss what Chris was just talking about, assessing and improving health status? And I'd love for you to talk about also who needs to be at the table, so how do you open that dialogue, Kurt?
Well, that's a great question, and I will not pretend to be an expert in this. I can give a couple examples of how we have done that. I mean, for us, I think I looked at the participant list. We got a lot of great organizations that are represented by our attendees today. A lot of folks doing lots of good work in this entire arena, and there's lots of good work to do. Marion, you referenced my long history of Floyd, and I was just thinking about that. All the things that we have done in this area, and it's not necessarily been some grand plan, although we're starting to get our arms around that. And in our time this afternoon, maybe we can talk about that some more. But so specifically to your question, I'll give a couple examples of how we've engaged the community, and it's really been by, I would say, just being attentive and paying attention. If I go back about 10 or 15 years, we had a vision to put together a breast center, and it actually grew out of one of our local general surgeons' own commitment. He said, whenever any one of our spouses has a positive mammogram, we get results to those spouses, instantly, within 24 hours. He said, why can't we do that for everybody? He said, we do it for those that we really care about, when it's one of us. Why can't we do it for everybody? And so we took that challenge, and we've created a No in 24 program where we do that now. And everybody had to rework their work streams, the radiologists, the pathologists. And so it's catching a vision sometimes is what is the start of it. And then we also put together breast outreach coordinators, and we started with women that had breast cancer in the community. And we put together that focus group and said, we want to do outreach to get women to come in and get testing. And we use them as breast health ambassadors, and they, as their task, would go out and on an ongoing basis, encouraging people to get mammograms. And then we also did mobile mammography. And we drive all over our service area and beyond, as a matter of fact. And every year we find women that have never had a mammogram before. And we found positive findings in cancer. And so that's a group that's, speaking of getting folks involved, we did that in that manner as I described it. I'll give you a second example. We were just from our community health needs assessments. Kelly mentioned that. That was actually a good part of government regulation that we all have to do every 3 years is community health needs assessment. And so we did it, and we took a look at several of our counties. And as we were reviewing it, we said, man, we didn't know this. And what we didn't know was that amongst our African American population, that we had statistically higher than in the rest of Georgia rates of cardiovascular death amongst African Americans. Now that's true across the nation, but it was really bad in a couple of our counties, and we're going, gee whiz. I mean, we need to do something here. And so we thought that the way to do it is not just to go out and start putting programs in people's faces. In fact, we learned that early on when we were working through Polk Medical Center. We decided we wanted to work with some of the African American churches. And so we had one of our very talented ED nurses, and she tells this story. It makes me laugh every time. And so she goes to the church meeting, and they're talking about some of the causes of the high rates of heart disease, smoke, and what have you. And she was giving that presentation, and this very large Black woman in the church member stood up and she said, yeah, I know all that, and I don't need a skinny white woman to come in here and tell me how to eat. And
good point.
It was an excellent point. And it's to the point of community involvement. I mean, you need to get the community themselves involved in helping to uncover what kind of programs need to be put together. And so that was really our awakening, that we can't just create a program, and out of our own heads and think it's going to be effective. And so as it related to our discovery out of our community health needs assessment, we assembled a group of African-American leaders and asked them who they thought would be good. And we put together our More Heart Committee. And we've been meeting now for a couple of years. We meet on a regular basis. During COVID, we have Zoom meetings. And we set as ourselves as our first project, and we've already put it together. We've got some of those blood pressure monitors that are automated. You go into the drugstore and it gives you blood pressure. We put them in a local church, in a beauty parlor, in a housing development, and then we've got one also in a community center in Chattooga County to the north of us. So those have been in place now for about 9 months, and people are using them, and people are finding out, hey, I got hypertension, and we've got a referral mechanism. And we did this with community involvement. Here's the idea. What did you think of it? Where should we put them? And the pastor in the church is promoting it, and the residents in the low-income housing development are promoting it, and the beauticians are promoting it in the beauty shop. And so those are two examples, or actually I probably gave three. Of you can't just, well, I guess you can. You fashion your own programs and hope people will adopt them. You really need to communicate with folks with how they want to be communicated with, and that's engagement. And you got to bring them to the table and say, okay, here's what we're dealing with. Help us think this through.
I love that, and I think we do. And we do have a lot of talented people in the audience. We also have a lot of young leaders that come to these meetings. And I love that story about meeting the people where they are, in the beauty parlor, in the church. That's outstanding. So, and the next question is for you as well, Kurt. It really speaks to, you've reached out to this community, but then we also have to create access. We have to address access issues. And, in your region, access to care and access to all of these services could be a bit of a challenge. How are you working to meet access demands in the current staffing and recruitment environment? And I'm going to get to Kelly and Chris because we're really going to talk about that. But what are some things you're doing to kind of improve access, and how are you addressing that based on the current situation that's out there?
Yeah, access it is really important, and people access healthcare in different ways. And so that was, back to these automated blood pressure monitors. I mean, we could go and do a blood pressure screening, but that's one time.
Yeah.
And so now we've got these, and this is a baby step. I mean, this is not a be all and end all program that we got 4 of these out in the community, but it's a baby step, but it's there. Now it's there and they can use it all the time. And we're going to maintain them and try and encourage folks to use them. So that was an important access point. Vaccinations. I mean, we stood up our parking deck and actually enclosed it. Originally, we put together a field hospital because we thought we were going to need it. Thankfully, we didn't have to use it. That was early in the pandemic. Well, we turned it into a vaccination clinic, and we vaccinated thousands of folks there. And we noticed as we were doing it that most of the folks showing up were, white folks. We're going like, we're not being real effective in getting this word out. So, after a couple of weeks of that, we went through our More Heart committee, and we talked to our pastors and our other folks, and we said, okay, how can we improve this? And so we've done now vaccination clinics over the last couple of years in a number of churches, in the housing developments, and so we can get, take the shots to them. And we're also doing it in schools. So, I mean, you've got to get to where people actually utilize, or maybe they don't utilize. You got to make it convenient for them. And again, that's engagement. How do we solve this together? And so, when we noticed people weren't coming up to our parking deck vaccination clinic, which was really well run and all, everybody was white that was going there. Then we started engaging people. How can we do this better? So to me, it's all about engagement and trying to make partners of the people you're trying to serve.
Absolutely outstanding. And I'd like to toss that question back to Chris as well. Probably a lot of the same things that they're doing in the Floyd region. What are some things, Chris, that you guys have been doing to kind of improve access, improve engagement, and really improve use of the services you have? I'm probably throwing you a curve, but I'd love to hear what's going on down at Phoebe. And Kelly, I'm going to come back to you, give you a minute. I'm going to ask you the same question because I think this is a really critical point we need to talk about. What are your thoughts, Chris?
I think that the circumstance of the market that we serve in the region is so disparate in that we're soon to be designated a level 2 trauma center. We're based in a small city of Albany. At the same time, we're serving rural communities, some that certainly don't have a hospital, let alone physicians.
Yes.
And so our Phoebe Foundation, the community, donated money to create 2 mobile clinics. And to Kurt's point, we anticipated we would go out and do screening and lab work and the like, and it became a substitute for administering vaccinations as well. But I guess one issue to consider is you never know what surprise you'll have in terms of connecting with the community. And one example from our mobile clinic is I'd understood that there was a gentleman who was there and observing, and he said, well, let me go round up some more people. And he himself drove around, knocked on doors, and created about 15 more visits to our mobile clinic. Now, as much as I like the Phoebe logo, I'm not so naive to think that pulling up in a church parking lot is going to create that intended impact on health status. But a local person that perceives us as doing the right thing is going to have a multiplier effect. And so I think that's important. The other thing I'll mention is that our CEO, Scott Steiner, when he arrived a few years ago as our CEO, he decided pre-COVID that we needed a simulation center. And I think many of our colleagues on this virtual meeting may have similar things, but we have a $5 million simulation center with multiple mannequins and simulations and videotaping to teach clinicians, notably nurses. But to give you a specific example, we bring high school students in to spend a half day up at our simulation center because our premise is that for us to improve the health status long-term, we need people that live and grow up in South Georgia to say, I want to be in healthcare and I want to stay in my community, preferably with Phoebe, but somewhere in our community. So I think in the context of health status, you need to plant seeds and have a very long-term horizon in measuring the ROI.
Absolutely outstanding. And Kelly, I'd really like your thoughts. I know I don't want to keep belaboring this question, but I love seeing what Kurt's talked about, what they're doing there, and what Chris, and I love that story about getting that local person to engage and be supportive. But I'd love to maybe for you to share a little bit, Kelly, about that question as well.
Well, for us, it started really early by taking diabetes prevention classes and chronic disease management classes to churches and to out into the community. And that helped build a lot of trust. And those are people who don't naturally trust healthcare. And health equity falls into what part of our goals are. So really generating those connections all around, but also creating camaraderie around the communities trying to do this together. And that it's not just Tanner rolling up in our van or sponsoring things. It is Tanner's out there working alongside educators, church members, everybody in the community. And the great thing about it is it's people that we would never come in contact with, farmers, for example, to create places where people can get healthy food. And so it's just created trust in us being a community hospital. I think it makes community hospitals are just uniquely adapted to these kind of programs in their community. You already have a lot of trust that's built there from having been there for a long time. But it's nice to reach outside of our walls and see how can we impact people where they are.
Yeah, I think that leads to my next question actually for you, Kelly, and then I want to come back. I do want to come back to that trust piece, and because I think there's a lot of people on this call that are going to want to hear even more about building a relationship in the community. And by the way, if you're on the call and you're watching, you have questions, please put them in the chat. We're going to have an opportunity later in the discussion where we can ask your question on your behalf or even invite you up to do it as well. Kelly, so, we're probably all tired of talking about it, but it's been with us now for a while, and COVID has made the whole pandemic has changed a lot of things. And so the question I have for you is that, and I'd love to get Kurt and Chris's feedback on this one as well, is how has it affected your partners, these community partners we've talked about that you guys have built relationships with and connected with, and how has it affected the partners you've developed in the community, and what have you done to help support that?
It's been very hard because being in a small community, you have a lot of small businesses. We had a lot of those businesses that supported our Get Healthy, Live Well initiatives. Mm-hmm. So you have a lot of people who have turned over in their roles, or their roles are no longer exist. Mm-hmm. So how do you keep people engaged? Kind of keep them close, but you got to keep them afar because of COVID. So it's been really tricky trying to keep them engaged. We've had a lot of our coalition meetings have still gone on during COVID. They've been, of course, virtually, but you have to understand that some people are not comfortable using virtual tools. Mm-hmm. And so a lot of health disparities are related to economic disparity. So they might not have the technology to do it. So we've had to get really creative and just constantly been in communication, trying to support them in the best way that we can. And the good thing is we had a couple of years under our belts before COVID started. But, you know, there's going to have to be a lot of road to make up after this is all over, just because the environment has completely changed.
Yeah, we're going to come to that in a little bit later, but I think that's important. Kurt, I would love for you maybe to share a little bit about, and they're probably similar answers, but how's COVID impacted your community partners, and what are some of the things that you've done to support them as well? And I want to hear also about Chris, because we know the story. A lot of us know the story about Phoebe and what they've had to deal with their partners. But Kurt, love to hear your input on that question as well.
Well, thank you, Maren. I mean, everybody has seen the statistics, and you know, how many folks have gotten it, how many folks are dying. We've got our local statistics too, as to in our region how many folks have gotten it and are dying, and how many are unvaccinated. I mean, there's a lot of bad news about COVID, to be sure, and we don't know what's going to happen right now. You know, whether we are approaching a peak, or I read an article this morning that our chief medical officer shared with me, and he said the gist of the article was, you know, don't get too confident that we're going to have a V-shaped event, and once we peak, we're going down again. And you know, it's not really good news. But with that being said, the positives out of COVID have been just incredible community engagement for us, because our organization, I'm very proud of what we've done. We have stepped up. We've spent the money to stand up facilities, you know, in our parking deck, and worked with the state as related to putting in a mobile 20-bed ICU out in our parking lot. We kept all our employees whole in the first phase, you know, while we were closing down ancillary services and our urgent care centers. And kept our urgent care centers open, but our primary care centers kept everybody whole, because we said we think we're going to need you, so we're going to keep paying you. And that's why you have financial reserves. You know, not every organization did that. There were organizations that put people you know, on short work time, and draw down your earned time and time without pay. We were among the organizations that didn't do that. And so we just approached this as all hands on deck for the community. And our physicians, our board members, our partners, you know, all responded to that, and responded well. And you know, if I could say so, they love us for it. I mean, and we set up vaccination clinics in the schools. You know, I already described one of them that we did. We kept our More Heart community going. And, you know, did those kiosks in the midst of all of this. We got them to help us to set up the clinics in the churches for the vaccination clinics. We developed a new and now growing relationship with 100 Black men. You know, and when we started that, they kind of looked at me a little bit suspiciously. Well, you haven't talked to us in the years prior. And I said, well, we are now. And I said, we intend to do better, and we need you. And So we've delivered on what we said we were going to do, and now they trust us more, and we're doing more things out in the community. So if there is a good thing out of COVID, and I think there are a lot of them, I mean, we've seen all of our coworkers respond heroically and admirably and answer the call. But another good thing is what's happened with our community engagement, as they've seen us step up and they see that we really are here for the community and we want to engage with them and we want to make things as good as we can. And, that's been a rewarding thing.
Outstanding answer. And Chris, share with us a little bit about that. And then we're going to talk about the trust factor a little bit more, because I think what we're hearing, I hear the common theme here is that building the trust in the community. But Chris, share a little bit about how, what you guys have done and how your partners have been impacted and how you've maybe build on that relationship a little bit.
Sure. And the circumstance, I actually joined Phoebe right as COVID broke out, and it was odd because I had friends and colleagues saying, are you going to Albany, Georgia, which is in the news in the top 5 outbreaks of COVID? And yes, I am. And a lot of it, if you can imagine starting your new job and you're sitting in the command center, which was our boardroom, and I'm sure some people look at me saying, who's the new guy with the tie and the mask? But I'm looking out at all my colleagues and just being wowed by their poise, their knowledge, and their teamwork. So if ever in my career, I thought, gosh, what a great place to land despite the unusual circumstances. Mm-hmm. But I think for Phoebe, we had a bias towards transparency with whether it's our CEO texting community leaders and board members with the latest update, or weekly press conferences, or publishing the data from our PR marketing team, Ben Roberts and Jessica Castle as specific examples. So we started with that, and I think that cultivated the trust that you're mentioning, Marion, because if the perception was you have nothing to hide, then that's a positive. And yet we could look across the country where there were some hospitals that the reaction was, wait a minute, is it risky to convey any suggestion that our hospital is overrun with potentially infectious people? So I'm proud of the path we took, and I think that created more trust with a broader group of constituents that historically did not necessarily know people or the capabilities of Phoebe Putney Health System.
I agree.
So, Kelly, I mean, this was a question we were going to have for Chris, but I think I'd love to hear your input on it as well. And Chris, what I'm hearing is from all three of you is that even though the challenges have been great and there's been a lot of tragedy, a lot of issues, that there's all these positives, and particularly about these relationships. And so the question for Chris was going to be, and I'm going to share it with Chris, but Kelly, I'd love your input on it. For those of you I'm throwing you a curveball, please forgive me. I just think it's important. What might you've done if COVID hadn't happened? Because it sounds like there's a lot of positives that have come out of the situation, but and I want to hear Chris's point on that as well. But I'd love to hear it from you as well, Kelly. What are your thoughts on that?
We had just started our food as medicine program, which is like a fresh food pharmacy model. Yep. And that included people coming for weekly classes, health assessments. We give out donations of food, and we had to pivot because people in the community aren't donating food to the food banks, which is where we would get our food. So we had to really pivot and try to figure out creative ways to meet the needs of the people who had already signed up for all of our classes. And then we had to pivot all of our community education classes to virtual. So how do you put those that technology in place where it's easy for people to use and people to be engaged? And it was, how do you do that when people are just so scared of coming to the hospital? How do you manage health assessments and things like that? So I think that our programs would have grown a little bit faster, but I think it also opened up new horizons for us in the virtual learning world that steps we probably wouldn't have taken before COVID, to bring all of our things virtual and really expand what the educational opportunities we were offering. So I think that even though I think we could have our FAM program could have been bigger, faster, I think our other programs benefited from COVID in that we were just able to reach a much larger market. In our service area is much bigger now with our educational opportunities.
Absolutely outstanding. Chris, what I know I stole your question and gave it to Kelly first, but I would love to hear what your answer is what might have you done if not for COVID, and then kind of where's that directed you now?
Sure. I think, Marion, a number of things. One is COVID precluded service line refinement. So the idea of adding technology or recruiting a physician subspecialist, some of those improvements had to be put on hold. In our case at Phoebe, we were gearing up for a substantial cultural investment and patient safety and quality investment in going down the high reliability organization journey, which other health systems have done. And we're just kicking that off in a formal way now, but we had to postpone it several times because of the COVID surges. Cancer screening and the like was not eliminated, but it was tempered by COVID for some of the reasons that Kelly mentioned about perceptions in the community. And I think fundamentally, it's been about rebalancing in that in the pre-COVID circumstance, I think our internal orientation was efficiency. And now with COVID, it's become capacity management. And before COVID, it was about increasing access. And now it's about ensuring just sufficient access. Do you have a bed available? Do you have a ventilator? So all of those were things that we would have liked to have done. And just to play off some of Kurt and Kelly's comments before, it struck me yesterday, and people that know me would say I sometimes come up with strange analogies, but it struck me that what we have learned is the exact opposite of the Wizard of Oz.
Okay.
And what I mean by that is there is no wizard. It's complex teamwork, not an individual. There is no kind of grand solution. And all this perception, we never needed the gifts that the people in the Wizard of Oz wanted. We've learned that our healthcare system, collectively described, has got heart, has got courage, and has got brains. And if anything else, we ought to be proud to all of us on this meeting be part of this amazing industry, even though there's some days or some hours that you think, please, not another memo on COVID.
I love that. I love that analogy. And my first thought was, is the yellow brick road has got a lot of detours, a lot of construction on it.
Well,
That was just my thought.
In Georgia, yellow brick road would need a CON. Just keep that in mind.
Yeah. Marion, I have something to tag on to that.
Yeah, please do, Kelly.
You know, when we were where supplies were not available, we were worried we were going to get isolation gowns, all of it. We found a local provider, this woman that had a business, a sewing business, and she did scrubs for national providers. And what she and her team of 5 ladies did is they made 300 isolation gowns in a week.
Wow.
And they did that for us. Not only that, but they prayed over every box that left their facility. They prayed for us. They prayed for our community. And it's things like that that no matter how long COVID goes on, I will always remember, because it is being part of the community and knowing there are people who have our back. And I think that that's what really has meant so much to me during this whole journey, is just that it's not, we don't live in our own microcosm here at the hospital. We need everybody.
Absolutely. And I'm actually going to jump to one of the questions in the chat, because I think it dovetails exactly into what you're talking about. Several years ago, when I first got in the business I was in, I had to work with this community hospital, tiny community hospital of 5,000 people, critical access hospital. And after I took a tour, the CEO asked me, well, what did I think about everybody I met? And I said, well, I got the impression that everybody here is treating everybody that comes through their door as their mother or their father or their grandmother or their grandmother or grandfather or their cousin or their brother. And he looked at me with just completely directly into my face and said, well, that's because it is their family coming through the door. And I'm like, okay, all right. So I thought about Kurt. Kurt, the question came up in the chat from Catherine Maloney about how does your community outreach that apply to your own internal workforce from a health equity perspective? In other words, how are you managing? Because it's all interrelated. Those are your population is also your internal people. So the question is, how does your community outreach apply to your own internal workforce from a health equity perspective? Kurt, I'd love to hear your answer, and maybe Kelly and Chris, you could jump in on that. And Catherine, thank you for that question. And you're muted there, Kurt. You'll unmute.
Sorry about that. When my phone went off, I muted.
Got it.
That's a great question, and this is very fertile ground for us. We've always prided ourselves on being a good employer, and in fact, one of our indicators of this is that biannually we've done surveys with national companies, and we've historically scored in the top decile. So we get confirmation from our folks, but we can't just rest in that knowledge that we're perceived as a great employer. I mean, we have got folks at the lower levels of income, especially that have issues, and we're becoming increasingly sensitive to that. And I'll tell you, you mentioned, Marion, we joined Atrium Health Floyd. Atrium Health has done a great job of that. And on our work plan for this year is to survey all of our employees, with a special sensitivity to those that are at the lower level of income. Because many of them, we're confident, are struggling with, economic issues, some of the basic issues that we've just talked about here in the population that we serve. It's resident in our employee population, and we need to be sensitive to that. So that's actually on our work plan, as well as what Atrium Health calls the minimum wage journey. And what we mean by that is that we want to raise the pay of those that are at the lowest amount. And we want to intentionally do that throughout our organization because if we can, we should. And furthermore, it's good business. I know, I'm sure I'm not unique in what I'm about to say. In our environmental services, in our food service, in a lot of these lower paid jobs, we've got incredible vacancy rates, and we're having a difficult time staffing and getting all the job done. Our managers are doing an amazing job in turning over beds and delivering meals with reduced staff. But part of that is we don't pay enough money to compete with the Hobby Lobby and McDonald's, and we've got to address that. And I'm rambling here a little bit, but the level of pay is important, and also the sensitivity to what those needs are, and that's on our work plan this year. We're going to do that survey. We're going to see what it reveals. I mean, I've got a sense of what it's going to reveal, and then we're going to intentionally begin to address some of those things. And we're also intentionally going to work on our diversity, equity, and inclusion efforts. Do we slice and dice that data? It's not all necessarily income related. There may be some other issues. And so I think it's important to be sensitive to that.
Absolutely. Kelly, I'd love your input on that. What are your thoughts around how are you guys working with your internal people to create health equity amongst your team?
One of the programs we have that's in our community health division is our employee wellness division. And what we do is we've been doing for about 15 years annual health assessments. But now what we're also doing is we're tying our health assessments back to health deductibles. So if you have heart disease or diabetes, we have programs that can help our employees with free medication, with free monitoring devices, with nurse calls, with dietitian consults, with certified diabetes educators. So we try to give all of our employees, regardless of what job they have, if they have a health struggle, we try to help them with that, and where it is no cost to the employee. That's not only, I mean, it's good for Tanner's bottom line, but we want our employees to be as healthy as they possibly can be. And we want them to be stewards of good health. And so we have on-site gyms, we have just all kind of educational resources, and they can join any of the educational resources we have available to the community, which are all free.
Mhm. Awesome. And for those of you who are watching live, please put your questions in the chat. We'd love, we've got time for dialogue here, and this is a great conversation that we're having. Chris, I'd love for you to share a little bit about, your footprint. The Phoebe Putney footprint is much like the Floyd footprint. It covers a pretty wide berth of that part of Georgia. What are some things you're doing for internally for to build health equity amongst your employees?
Well, similar to what Kelly said, for a number of years, we have had our Health Works facilities for fitness that our employees can join for free, and our community members can also become paying members to create some fitness. I mentioned our community gardens.
Yeah.
And we also are very focused on culture. And we can talk about attracting talent, but retaining it is, what's the training and talent of the manager, the immediate manager? What's the organizational culture? So for example, last May, we proceeded with our employee engagement survey, and we also invested in diversity and inclusion. And I think Dr. Jennifer Williams may be on this meeting, and she is our system-wide director of diversity, engagement, and inclusion. And she's made a big difference. We just started business resource groups where we have different constituencies in the organization open to anyone of us have a special interest. And I think we are trained as healthcare executives to look at market share and volume and financial numbers, but at what point do we step back and say market share applies to the level of talent that you bring in and retain? So some of our business metrics need to be applied in different ways, from the scale and nature of the talent you bring in to retaining them and to their perspectives. And so we're trying every possible lever that we can do related to that. And I think we're getting some traction, notwithstanding the labor market enveloping the whole world right now.
Yeah, I love what you just shared, because I think it's not just about that individual, but how's our culture, how's our management, how's our leadership team addressing those needs of the employees, and on a lot of different scales, in a lot of different ways. Kurt, and I'm open this question up to switch gears just a little bit, but what new modalities or programs are your organizations considering to improve community health in the future? What are some of the plans that you might have? I'd love to hear your input, Kurt, and then Kelly and Chris. What are the plans? What's the next thing you need to be doing?
Well, we've got some exciting times ahead in our community. We joined Atrium Health, and as a part of that, we were able to get a pretty sizable amount of money into a new foundation. Oh. And I've just worked with some other leaders at Floyd putting together this new foundation. We got a very diverse group of individuals who volunteered to be board members, and this new foundation has been put together in order to address disparities of care. And so the new foundation is going to have in excess of $150 million in it. And so as we invest that, if we get 5% return, which we ought to be able to do, over time, that's some considerable, that is a considerable amount of money that we'll have available to us to devote to disparities of care. And so our task is to get our foundation going, which we have, and select our board members, which we have. And now we've got to set up our investment policy, and we got to get our arms around the disparities of care and what do we want to focus our resources on. So this is some exciting work that is I'm going to be engaged in with this board for the next couple of years. And Atrium Health in Charlotte is ahead of us in terms of how they address disparities of care. They're a national award winner of the American Hospital Association. And we're leaning on them in terms of helping us to put together what we want to do here locally. And so we're going to get a great assessment done I mean, we've got our community health needs assessment, but I'm not sure that is granular enough. I mean, we're going to try and get our data together. We're going to do a national search for our foundation director, and then we're going to spend this money. And we are going to be, as I've learned from some folks that know more about this than I do, they said, you're not going to be transactional. I mean, you'll do transactions. You need to focus on being transformational. You're in this for the long term with this foundation. And what is it you want to focus on? Not 1,000 transactions over the next year. You want to focus and address some issues. And so that's what we're going to work on. And Floyd has done a great job through the years, but now we've got this foundation that's going to sit alongside of us. And we're going to be creating this exciting transformational opportunity. So I'm pretty charged up about it.
Yeah, that's exciting. And by the way, Atrium manages the hospital in my hometown of Concord, North Carolina. And I get to hear about them, both positive and negative, and they're doing a great job. But my family's still there, you know, cousins and brothers and sisters and all that. But so I absolutely very familiar. Kelly, tell us a little bit about what Tanner Health's got planned, because as part of the communication role that you play, you must be the one sharing that message. So can you tell us a little bit about that?
Well, we are planning for Open Heart, which is basically a year away. That is one of our big focuses over the next year. And then we are working really closely with the ambulance and police departments here for mobile crisis units. That has already been a really successful program between us, the police department, and our local ambulance service. That's been really great to keep in our community and to grow in our community. We are looking to expand senior living. We are starting a second development here in Carrollton. So that's something big. We feel it's really needed in our community and in our service area. So that's what we're working on. And from a community health standpoint, we are looking for ways to expand our educational offerings. How can we go back to some in-person things with some of our interior spaces? But just try to keep the work up going that we had started before COVID.
Outstanding. And over to you, Chris. You joined in April 2020, and several other people I know have come down to Phoebe. There's a lot happening at Phoebe Putney. What's the future look like in terms of community outreach, community health plans? What's the next thing for you guys?
Sure, Marion. I'd sum it up by saying every health system or physician practice or the like at any given time is either involved in the core projects or the cool projects. Yeah. And Phoebe is knee deep in both. So gotcha. Last week we submitted a letter of intent for a $140 million project to expand our ED, our ICU, and ultimately our NICU capacity. And that's been in the works for many years with community involvement. On the cool side, I think the partnership that we have with Albany Area Primary Healthcare, which is an FQHC and nationally respected, is a touch point that's vital to the future. So right now, as specific examples, we're working on one portion in the geography where both we and AAPHC have resources. And we're doing a detailed business and space plan to say what is the highest and best use of our resources, what role, who's going to do primary care, who's going to do specialty care. And to give you a specific example, Phoebe Putney at our mothership hospital, Phoebe Putney Memorial, we looked at people from a specific zip code and we said the 100 patients that have had either 2 admissions to the hospital or 2 ED visits in the last 12 months. 100 patients generated in excess of 1,300 ED visits and $19 million of uncompensated care. So a CFO might get excited by that, but I would push it back by about health statuses. How do we intervene in an earlier setting and work with these patients? And what our primary care physician and AAPHC's physician leadership have come up with is what's called intensive outpatient care. where basically we're going to have perhaps 100 people that can come in and come out, but they're going to be monitored. If you can think of a covered life for their health well-being, not necessarily because of any capitated payment, but because it's the right thing to do. So that's kind of an example of a cool project that complements the core projects.
Yeah, I love, that's a great example of creating trust in a population that might be really adverse to trust in the healthcare system, except when they absolutely need it, when they go to the ER. And so I want to come back to that. I'd like to start with you, Kurt. You hit on it a lot when you were talking about building trust in the community. And, you know, you've talked about some of the approaches in the different stakeholder groups, but where was trust, where were there breakdowns in trust that had to be rebuilt? Where were those gaps in different populations or different groups of people that might have been disenfranchised? And what are some, you've talked about it a little bit. I would love maybe to share just a moment more about how you went about rebuilding trust or building trust in those populations.
Well, I wouldn't say necessarily that we had erred in any manner or fashion that people felt disenfranchised, but you know, as you talk about the disparities of care and the social determinants of health, you know, structurally there are ways that people get disenfranchised. I mean, just by the very structure of society. You know, they don't feel like they're included. And, you know, folks that don't have a relationship with a primary care physician, I mean, some of that may be because they choose not to, because I know there are folks that just like going to the urgent care. They don't want to see, but I will guarantee you that there are folks in lower socioeconomic strata that don't necessarily feel welcome. I mean, because, you know, I'm expected to pay, and these aren't my people, so to speak, when they go into the waiting area. And so you're just not comfortable. And so I think that for all of us, we've got to have a sensitivity. You know, we who are leaders of our health system, we got to have a sensitivity to all these different populations that we serve. And, you know, it's for years, hospitals, and we were this way too. I mean, hey, we're not for profit. We operate an emergency room. We take care of all the individuals that show up. We run EMS. We pick up everybody that needs to. We're doing our job. And we were. But, you know, now well, as we have more knowledge and as we are now more aware of diversity, equity, inclusion, social determinants of health, disparities of care, it's incumbent upon us to understand how that is represented in the communities that we serve, and then to figure out ways to reach out and better deliver that care. And as we do that, and as we live up to, you know, what we're charged to do, first of all, you got to own that. And I think we are owning that now. And then as you start delivering on that, you know, I mentioned 100 Black men of Rome, you know, when I first engaged them, they're going like, well, where you been, you know? And so, you know, now we're with them and we're doing programs with them, and they're going like, you know, I run into them in the community. And I went to the Martin Luther King local celebration and helped pass out lunches. And, you know, I was side by side with some of those guys, and we're developing a relationship. And so I think that's where it grows. As we who are healthcare leaders embrace that challenge, we're supposed to embrace that challenge. You know, now that we're knowledgeable of it, that's what we're supposed to do.
I absolutely agree with you. I love that. And so we've got some of the questions coming in, and again, we have a few more minutes. This kind of switched gears a little bit. This is a question that came in from Gina Tipton, who you guys probably know, and she's one of my committee members and just an outstanding leader. But she's really curious about how each of you amazing leaders, stay recharged, because we know everybody's tired. I mean, every day when I talk to my clients and talk to people in the field, everybody, people are getting worn out. I mean, they're just getting worn out. And she was just curious. I'd love to start with Kelly. You know, what are you doing to recharge and get your focus back? you have to expend all this energy, and your team does. What are some things you're doing, and what are some of the things your company's doing to help your leaders just recharge?
I mean, for me, spending a lot of time with directors and with our physician leaders is really important because it keeps the focus on what it is we're trying to accomplish here. Because my team is really focused on external communication, they're the ones that deal with all of the negative emails, negative comments on social regarding the vaccine and all of the things that might be happening at the hospital. So it's really nice to talk to the physician leaders to see if there are ways that we can make an impact. And I think that that's where I get energy from, is to see what can we do to help them. And just one of my greatest joys about my job is being able to tell their story. And so that's sort of how I get recharged. I feel like that's just a great thing to be able to talk about the important work they're doing.
Absolutely. Chris, you talked about when you first got there, you were volunteering and being in the trenches with everyone. And I know you got a lot of different roles, hats you wear. What are some things that you're doing to recharge? And then also anything going on within the team there that to support your leaders?
I think it starts with trying to be a role model, and our CEO, Mr. Steiner, is the first one to tell all leaders and team members that take a break. We're proud of you. You've accomplished a lot, but manage your mental health, your physical health, and don't be shy to say, I'm going to take a week off and try to recharge. Yeah. I think our chaplain program, our employee assistance program have been out in front as well. And I really do worry that the hidden pitfall we have, not just COVID specific, is mental health welfare in the community and among our team members. And we can't really measure that just yet. And I think, some of it is just this idea of what is the objective. And last week, the senior executive team, we talked a little bit about, we keep having these imaginary deadlines when things will get better. It will be by the new calendar year. It will be by Labor Day. And it didn't happen with the surges. And so what we talked about is, should we rather create this sense that whatever comes our way, we've demonstrated the fortitude and the stamina to get through it, and we will do so again, instead of creating these psychological finish lines that never seem to occur. And so some of it is not just kind of playing your own mind games, but trying to take a different perspective.
Yeah, absolutely. Kurt, this is a question that came in early and you were talking about the situation around your breast cancer program. And this came in from Dr. Darlene Nabby. I know she's over at Fort Benning. She said that you made a great point speaking on vision to spark change in the community with the breast cancer outreach. And her question is how did you, Kurt, when you were met with resistance from the community, persist with your vision in your community outreach? Not just about the breast cancer piece, but how did you persist when there was this resistance to get change taking place? Love to hear about your answer to that question.
Yeah, it's a good question. I mean, it depends upon the project, but as it related to the breast center, it required a rework of each of the specialists' workflow. I mean, the pathologist had to agree to move the reading of those tissue samples to the front of the line. The radiologists had to agree that they were going to move and dedicate resources to read those studies and read them quickly. The general surgeons, and it was their idea, had to agree that, within a short period of time, they would make an appointment within 24 hours to get with the patient. And so we had a lot of pushback on that. And they said, well, wait a minute, we're delivering good care. Why are we doing this? Nobody else is doing this. We said, well, exactly. But we're going to do it. And particularly the radiologist, we had a very memorable meeting. And, that sometimes you just got to draw a line. And we did. And we found a radiologist. And this is at the early stages where the images were digitized. So
Yes.
you didn't have to have a physical film. And so we brought the radiologist from Atlanta and a radiologist from Atlanta. And we said, she is willing to read all of these tests as we send them to her. Now, you can change your workflow or she's going to do them.
Oh, wow.
And they said, we'll get back to you. And they changed their workflow.
Yeah.
And now they love it. They are front and center promoting what we have done. And so, I mean, sometimes it's you draw a line in the sand, and that was a line in the sand with that group of radiologists at the time. Now a lot of those guys have retired, and actually they did a 180. You know, after we got it rolling, and they said, y'all are absolutely right. We should have bought in early on. And you know, sometimes these things for administrators, they might be career limiting events. You know, you think about it but sometimes you got to make a call. Is this one worth doing it on? And we did. So we got pushback on that. And so sometimes it just takes that. It takes, you know, how important is this? And can you marshal all of the resources that you can to make it happen, and do that, and play your cards. You know, it's like Georgia versus Alabama, and the Bulldogs won. You know, so they had their game plan. I'm an Alabama fan, by the way, and I think that Saban did a remarkable job with what he had. I mean, he had second string receivers, and you do the best you can. So.
Yeah. I had to learn how to say "Go Dogs," but being from North Carolina, we don't play football out there. We play basketball. So I had to be neutral. So I kept saying "Roll Dogs," "Roll Dogs," and nobody appreciated that at all. So thinking, Kelly, you made a comment in the chat, and I think it was probably a reference to what Chris was talking about earlier. You say it's a constant game of pivot and run. I'd love for you to expound on that a little bit about what we were talking about earlier.
Well, one of our former physicians went to a hospital in California, and I read an article that he was mentioning that their COVID strategy is pivot and run.
Yeah, gotcha.
So I thought that's really everybody's strategy at this point. And I think that if COVID's taught us anything, it's to be flexible and to think outside the box, because you know, how would we ever have thought of some of the challenges that we've dealt with over the last 2 years? And I think it's been a huge growing experience.
Go ahead.
I wanted to mention something that Kurt was talking about. When we started doing vaccine clinics, we were looking for the biggest space we could find, because we wanted to do as many people as possible. We wanted to make sure we had great traffic flow, all of that. So we used one of the Baptist churches in town. And so what we learned later is there is a huge segment of people that would not come to a Baptist church to get a vaccine. And because they felt uncomfortable, because of the language barrier, because of the paperwork required to get a vaccine.
It's the Methodists. The Methodists won't come, will they?
Maybe so, yeah. Well, we ended up doing vaccine clinics, like I think that Kurt mentioned, out at the Latino churches, where we had to get our staffers that spoke Spanish, because there were worries about, where's this paperwork going to go? Like, is this going to report me to, you know, immigration and things like that, that you just try to get it done, but sometimes you get a little bit of blinders on with how fast, because you have to get things done so quickly. But yeah, sometimes you have to take a step back and go, oh, I didn't think about that part, and just pivot and run.
I love that. And we're running out a little bit of time, but I want to come back to something that back to Chris. And I love that pivot and run. I actually wrote that down and you're right. I've watched that play out across the markets so I'm going to steal that one. Chris, I want to come back to you for a moment in regards to what Kelly just talked about. Is you have in that region a lot of different populations, a lot of different cultures, a lot of different pieces. I'm curious maybe what you guys have learned about how to communicate with those different, talking about social determinants, health and culture. You mentioned that earlier. What are some things that you guys have done to really communicate? I love the fact that people wouldn't go to the Baptist church. And by the way, I grew up a Methodist, but went to 2 Baptist universities, so I was able to make it. But Chris, tell me a little bit about what you guys have done to kind of address all the different cultures you have in that region.
Well, I might refine that to say, I don't know that there are different cultures out there in the community as much as we want an organizational culture at Phoebe that appeals to all those. And so
better, yeah, I think I agree.
I think by that transparency I mentioned, by having the press conferences, the communications, and having our leaders out there in the community where they can be is all part of it. And what I find fascinating about working, and I've worked around the country as a consultant, and by the way, for any of you consultants, there is life beyond Delta Airlines working in a health system. Yet what's interesting about South Georgia is that you have to look at not only the delivery of care, but what are the enablers? What are the businesses that are coming in here? Why are they not coming in here? Whereas I think if we were to look at Atlanta or other large cities in the US, the strategy is more akin to Coke and Pepsi. We're going to have some growth. Now, how do we get our fair share and drive more access to our organization? What's fascinating in South Georgia and other areas, even in our state, is you're dealing with other either enablers or disablers to success. One other point I just want to mention quickly is what's happened in COVID, I think, is going to redirect the career paths for young healthcare managers in training and in the future. So when you talk about setting up, Kelly, a vaccine clinic, that's about quick thinking, operational design, lean management. You talk about talent acquisition and retention. I think HR in healthcare is going to have much more emphasis going forward. So the old days of, I want to be a hospital administrator and kind of this narrow attainment of that one goal, I think it's going to be much different now for people and what paths they take. Someone may say, I want to create substantive partnerships between departments of health and hospitals. That may be a career path in its own. So I think that part of this is exciting.
Really exciting. I had a question come in. I think it's a great question from Heather Jameson. Many of you mentioned your community health needs assessment and how it drives strategies. And oftentimes the health needs identified by these reports, sometimes outside the hospital expertise or scope. A lot of you mentioned collaboration with the community partners. Here's the question. What has been a memorial or meaningful collaboration and that you've developed, or what health needs have been difficult to address? So I'll open up, I'll let Kurt go first, but Kelly, I'd love to hear your input, and as well as Chris. What's been a memorable, meaningful collaboration that's come out of your your community health needs assessment?
Well, I've already mentioned it. I mean, our More Heart program, we're working with our African-American community and getting them engaged. In fact, we just said our next meeting is going to be February 1st, kicking off Heart Month. And we're going to have another Zoom meeting and talk about what we do next. And so, we've now got a relationship with 12 important leaders and that we didn't previously have. I mean, I knew most all of them, but we weren't sitting around the table trying to figure out, okay, so what do we do next? We've done this. What's our next step? Because we got more work to do. So that's mine. I hope I end up with more because, we got a lot more work to do, but that one's top of mind.
I love that one. Kelly, I want to kind of redirect that question just a minute, because one thing about a critical health needs assessment is that's a communication. If you take that assessment, you take the survey, you got to do something about it. So maybe you can speak to that as well.
Yeah, one of the big things that came out of our community health needs assessment survey probably 10 or 15 years ago was the need for behavioral health services. And just like community health is sort of not going to add a lot to your bottom line right away, behavioral health is a little bit like that too. But we established community outreach with our behavioral health to include placing counselors in schools. And our effort there was just to give kids an avenue to talk to somebody about all the things they're dealing with in their lives, to get them additional services if they need it. And that has been a hugely successful program. The teachers and the principals love it. The parents love it because kids can go speak with a therapist right there at school or after school. And it just really puts the care where those kids need it. So to me, that's one of the biggest wins from our CHNA.
Marion, let me do
jump
a
in.
quick closeout on that.
Yeah.
On our website under Health Matters, we have software that enables you to look by county, by zip code, by disease state, what the status of your community is. So we're trying to push that insight out there. In answer to your question, I think a key approach is to have a standing community group of people that have participated in your China process that you can activate if there's a specific emerging issue. And I would say the most elusive issue for us has been health IQ. How do we get the community to recognize different essential things about managing their own health? It remains very difficult.
Outstanding. And I think we're at the point of wrapping up. Sharon Fonto, Christopher, thanks for sharing your insights earlier on caring for the mental health. And Kelly, what you just mentioned on behavioral health needs, so important. And I know, Kurt, you have a large behavioral health program out in your market. So I love that. I think that's a great way to tie a bow on it. You've all been outstanding. Thank you so much for being a part of this GAHE group today. And we were talking about improving the health status of your community. And I'm glad your communities have you guys in it. And John Cuban, I'm going to throw it back to you. Marion Spears-Carr, thank you so much for letting us be a part of this today.
Awesome. Thank you again, Marion. And to our panelists, thank you. Really great discussion. I mean, I'm like taking notes of some of the great work and things we can implement and look at here, and hearing from such a wide variety of panelists has been really interesting. So thank you for being here and being part of ours. Also, thank you to Gina Tipton, Hugh Jackson, Nicole Denman, and our programs committee for organizing today's meeting. They do a ton of work for GAHE, the programs committee, and we are so thankful. Thank you again to our sponsors. We appreciate all you do to provide leadership for the healthcare industry in Georgia. Special thanks to ACHE for hosting today's program so that we can offer you face-to-face credits virtually. Also, as a reminder, please be sure to complete ACHE's meeting evaluation. You will get that. Your survey feedback will be a great way to help us as we continue to improve and strive to get better with our content. And now I will close my portion and turn it back to Guy Morris at ACHE for a few more closing announcements. Guy, over to you.
Thank you, John. On behalf of ACHE, I want to thank our chapter leaders that planned today's session, the moderator and panelists, and all of you for your participation. Please complete the evaluation link, which is in the chat link right now. And it will be available. It will be open for 1 week, excuse me. The direct link is in the chat box now. You can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the helpful links section on the right side of the screen. From there, click on the Access My Courses link and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of face-to-face credit posted to their My ACHE account within 2 weeks of this session in the My Education Credit section. That concludes our session, which is copyrighted in 2022 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone. Have a great day.
Thank you, everybody. Great discussion. Thank you so much.
Thank you.
Thanks, everyone. Great session, Miriam and panelists.